Good morning, everyone. Thank you, Chairman. First of all, I would like to thank Professor Ciao and the whole organizing committee for inviting me at this very important conference. For me, it's the second time I go in Russia. The first time was in St. Petersburg during the first nationwide conference about cryosurgery. I come from Italy. I'm an interventional radiologist, and I work in an oncology hospital in Cagliari, in Sardinia. And in the next 20 minutes, I will talk about cryoablation of the kidney. I need for some consideration with increasing of use of abdominal imaging, the incidence of discovery of small tumors more frequent. Very often these tumors are asymptomatic, small, and detected in early stage. We know that radical nephrectomy in renal cell carcinoma is considered the gold standard. That in small tumors, the partial nephrectomy has demonstrated results comparable to radical nephrectomy for tumors no larger than 4 centimeters. 4 centimeters is considered, less 4 centimeters in diameter is considered a small tumor. Despite the continuous and rapid evolution of open surgery, both percutaneous and laparoscopic ablative techniques achieve the same results compared to surgical techniques. We have different ablative techniques. The advantages of the ablative percutaneous techniques are due to some advantages. Perioperative morbidity is lower, the hospital stay is usually shorter, clinical recovery is faster, and with ablative techniques, we have the possibility to treat subjects who are not candidates for surgery for their clinical conditions. To select the patient for percutaneous ablation, we need to follow the oncologist guidelines, which recommends that the patient with small tumors and or significant comorbidity are unfit for surgery should be considered for an ablative approach, for example, cryotherapy and radiofrequency ablation. This is a high level of recommendation. The treatment bios has to be carried out as standard, but the level of evidence is low in this case. Microwave ablation, laser ablation, high-intensity diffuse ultrasound ablation are considered still experimental in character. The next step is to consider cryoablation and partial nephrectomy with open, laparoscopic, or robotic surgery. Some studies show not a significant difference in terms of overall survival, cancer-specific survival, recurrence-free survival, disease-free survival, local relapse or progression of disease. But we know that the hospital stay is shorter and surgical blood loss is lower if we consider cryoablation. Also, active surveillance is an option, especially for older patients, because small renal tumors have low risk in terms of cancer-specific and related mortality. But active surveillance is used with monitoring with serial abdominal imaging with delayed intervention reserved for tumor which is showing clear clinical progression during follow-up. But at the moment, active surveillance is not recommended in younger and fit patients and especially for large masses of diagnosis outside clinical trials. Also, we need to consider the patient's stress, because the patients who have a cancer often desires a minimally invasive and non-surgical alternative approach to solve this problem. So to select the patient, we can select the patient to treat with the curative aim, especially patients at risk of developing renal insufficiency due to renal function limits or a single function in kidney, patient with previous radical or partial nephrectomy, patient with high risk of developing more kidney cancer, for example, the von Hippel-Lindau disease, which who have different tumors, renal tumors during their life, transplanted kidney, and patient with high risk, high surgical risk due to their comorbidities, for example, advantages, age, and disease, etc. But with cryoablation, we can select the patient to be treated with palliative aim when we have large lesions to achieve tumor debulking, control of pain, control of hematuria, and also patient with primary renal cancer and metastatic disease. In this case, it's important to treat the tumor to preserve renal function, and also with cryoablation we can treat a single or more multiple metastases. So we have a different approach to reach tumors in open or laparoscopic and with percutaneous imaging guidance. In this case, in this last case, we have disadvantages and advantages with this approach. These advantages are due to difficult to check tumor margins, risk of injury adjacent organs, especially when we insert the needles or during cryoablation. Advantages because the less invasiveness, the repeatability. It is important when we have to retreat the patient for recurrence or residual tumors after ablation. And also, as I mentioned before, short hospitalization times. The image guidance are different. Principles depend on the choice of the operator. We have MRI, which get a better visualization of the eyeball, and computer tomography. CT scan is more widespread, and also ultrasound guidance for their easy of use. If we compare the radiofrequency and microwave ablation with the cryoablation, this meta-analysis shows that cryoablation is to prefer because is less often after radiofrequency ablation. The local relapse is low, rate is low, and the local tumor progression is low compared to radiofrequency ablation. But to reduce the incidence of complications, we needed to treat only patients with esophageal or intraparenchymal tumors and central cancer, intracapsular, extended to the renal sinus and mixed tumor with both components, sinus and extrarenal. Is better to send for to surgeon to treat this second group of patients. So, as we know, cryoablation is a highly innovative technology, already experimented successfully in the treatment of malignant prostate tumors. But actually, cryoablation is also possible in the treatment of malignant tumors of the bone, breast, pelvis, lung, pancreas, liver, and obviously kidney. In our institution, we use an argon-based cryoablation unit, which is composed by a gas distribution apparatus and workstation and a selective dose cryotherapy, which are very thin needles. Once the needles are inserted into the tumors, argon gas is circulated inside them. These gases are rapid freezing of tissue with the formation of iceberg. After 8 minutes of freezing the tumor, we perform using the same needles the rapid thawing of ice sphere with helium gas, followed by a slow passive thawing. The freezing thaw cycle is repeated twice to improve the number of cell distance from the needle. What about the biopsy? In the lecture, there are several papers in favor or against the biopsy before ablation or before surgery. In favor of biopsy, differential diagnosis among benign and malignant tumors, and to evaluate oncology therapy. Against complications, especially hemorrhage or seeding, false negative, inadequate sampling, adequate pathodiagnostic sampling. So in this case, we need to repeat the biopsy. So in our experience, we provide biopsy only immediately before cryoablation. The technique consists in different steps. The first one, we obtain a scan, CT scan. This patient, for example, is in prone position, and we decide before ablation how many needles and the dilation we use to cover completely the tumor. It is important to check the correct position of the cryoprobe because the idols have to cover completely the tumors, avoiding relapse or residual tumor. The electronic reconstruction allows us to see the eyeball, such as in this case. And sometimes we insert one or more thermocouples inside or around the tumor to measure the temperature locally, avoiding undesirable images of structures around the eyeball. The temperature is continuously monitored during cryoablation. The follow-up consisted in get CT or MRI scan at 1 month and every 3 months from the first year, every 6 months from the second year. The typical aspect with these images are both eyes, such as this case, as you can see, the tumor treated presented a large hyper-density area due to the necrosis of the tumor, and around the tumor there are a rim of granulomatous reaction. This is a patient treated before for ICC with radiofrequency, but this tumor in the left kidney was treated with cryoablation. It is extremely important treating the base of the tumor to reduce the vascularization from the kidney. And so we need to insert the needles very, very close to the base of the tumor. This is the CT scan get after 1 month. As you can see, there is a complete lack of contrast enhancement of the cancer. What about complications? hemorrhage, hematoma, hematuria are more frequent, but in general, complications and side effects are unusually by using cryoablation. Infection, abscess, fistulas, kidney failure, fracture of the eyeball is a very rare but very important complications, and to avoid this complication we need to avoid early removal of the growth, but wait just several minutes before removing the cryo growth. This is a patient complicated by an hematoma, two hematomas in the posterior thoracic wall during insertion of the cryoprobes, and after biopsy. After biopsy, there is a second hemorrhage, but we continuously treatment with cryoablation of the tumors, and the hemorrhage, as you can see, is stopped. Sometimes there are particular clinical situations to be considered, such as this younger patient affected by von Hippel-Lindau syndrome. The patient presented 3 renal cell carcinoma, one in the left kidney and 2 in the right kidney. Collegial decision between urologist, oncologist, and international radiologist is absolutely necessary to decide the treatment. In this case, the left kidney cancer was treated by surgery because the tumor infiltrating the renal pelvis, and the 2 right tumors was treated by interventional radiologist. But as you can see, one of them, these tumors, is very close to the colon, so we need to avoid the complications of the colon, and we perform hydrofixation before cryoablation. In this case, as you can see, the colon is moved and distant of the site during the treatment. This is another patient, young patient with bilateral presentation of renal cell carcinoma. The left tumor is large and infiltrating the pelvis, so the surgeon treated this tumor, and the last one is very small but situated in the right kidney, treated with cryoablation. This is the tumor. As you can see, the necrosis was complete. But also, when we have recurrence after laparoscopic therapy, we can use the percutaneous cryoablation. This patient sent by a urologist who performed the first cryoablation, but as you can see, the large scar, due to the large scar, the urologist asked us to treat this patient. But for us, it's not a problem scar. And so we treated the residual tumor, the recurrence tumor, to be exact, and as you can see, after 3 months follow-up, there is a complete lack of contrast enhancement of the tumor. So this is a rare case about tumors developed in horseshoe kidney. As you can see, the tumor is located in the left kidney, treated with cryoablation. This is the results before, after ablation, and as you can see, complete lack of contrast enhancement of the tumor. So in my personal experience, I treated 33 patients with 40 renal cell carcinoma, 4 in single kidney. In size of the tumor was 2.8 centimeters medium, from 1 to 5.5 centimeters. 2 patients were retreated. 97% complete necrosis in a median follow-up of 40 months. We had the hematoma without blood transfusion. To conclude, percutaneous ablation is a safe and effective treatment of kidney cancer with curative purpose in selected patients. In the choice of ablative technique among cryo and RFA, the first is to prefer for the lower rate of local and systemic recurrence and the lower rate of complications. The selection criteria include patients with small and large renal tumors considered unsuitable for surgery for comorbidity stage 7. Follow-up after renal cryoablation by using CT, US, or MRI is necessary to evaluate a possible residual or recurrent cancer, which could be early treated. Thank you very much for your attention.
Thank you, Professor Stella, for this excellent talk. Maybe any questions?
Thank you so much for your nice presentation. And this is very nice personal experience, patients with renal carcinoma. My question is, how did you verify renal carcinoma finally? How did you verify renal carcinoma finally? So, another to say, did you take biopsy, percutaneous, intraoperative, preoperatively, or postoperatively? Thank you.
Biopsy is performed before ablation, but we prefer to avoid biopsy and in the second time to perform ablation because sometimes there are hemorrhage after biopsy, and we can use biopsy just immediately before. But all, if the patient doesn't need for chemotherapy or for example, older patients is not need to use biopsy because the diagnosis is clear in the major of cases by using MRI or other techniques. So,
thank you. In patients with small renal carcinoma, did you verify or not usually?
Sometimes it's difficult to perform a biopsy if the tumor is very, very small, such as the case so before. But the patient presented enhancement with MRI or CT scan, so it's simple to ablate the.
One more question for Dr. John.
Thank you very much for your excellent presentation. My question is, what do you personal expression regarding future of percutaneous cryoablation in renal cancer? I mean, in all patients, not only with comorbidity, just like radical procedure based on your own experience long-term result.
All patients can be treated with radical to be treated completely or palliative, but it depends on the different things, size of the tumors, the comorbidities. So we need to treat or reduce the tumor to reduce the hemorrhage or to treat completely the tumor. So the older patient, I think, is the best choice in the future to control this kind of tumors. It not need partial effect, I think, but the results are the same. And so in other patients, we prefer to use the cryoablation in percutaneous or laparoscopic manner.
Just have a simple question because I'm not so familiar with the methods, but when you compare RF and cryosurgery, do you have the same limitation when it comes to the size? I understand also when the tumor is located close to big vessels, is it any different between the two techniques that you need to, or advantage of one over the other?
The difficult to insert the needles are the same. The difficult. When the tumors is close to the vessels, with the radio in contact, especially in contact to the vessel, the RFA are more dangerous with respect to cryo. But with cryoablation, we saw exactly, we can see exactly the eyeball. And in the limits of eyeball, we have 0 degrees, and with 0 degrees, we haven't problems. And so the very difference between RFI and cryo is the possibility to see exactly what is the necrosis which we have.
Yes, right, okay. Thank you very much, Professor, again for your presentation. If you have time, we should